Now, after we work out the heart rate, the next thing that we can identify is whether the rhythm of the ECG is a sinus rhythm or not. And that basically means that we look at whether there is a regular presence of a P wave on the ECG. Now, looking at the rhythm strip, which is the bottom strip denoted by lead 2, we can see that although it's small, there is a small ECG P wave present pretty much across all of the waves that we have here. And that indicates that in addition to the heart rate being 69 beats per minute, it's also a sinus rhythm. Alright, so those are two positive tests so far in identifying whether our ECG is normal or not. The next thing that we'll be looking at is what each of the different leads on an ECG represent. So firstly, we've already looked at lead 2, which is a representation of the action basically of the heart. So if we quickly draw the heart here, once again, it's basically measuring the electrical conduction signals as they move from the top right to the bottom left. Now, the other leads on an ECG trace represent other essentially points of view on the heart. So if we have a look at lead 1 here, if you're familiar with the triangle that represents the direction of electrical impulses in the heart, lead 1 actually goes from the right top to the left across. So this shows the direction of action potentials this way. If we take the heart as being here, it takes the heart signals to be that way, lead 2 is that way. Now lead 3 on the other hand takes heart signals that way, and essentially it shows if there's any indication of a right axis deviation on our heart, which can signify the presence of right ventricular hypertrophy or any other pathology associated with the right side of the heart. On the other hand, AVR, AVL, and AVF all represent different parts of the same triangle. So lead 1 is this way, lead 2 is that way, and lead 3 is that way. AVF I remember as AV fall, so things fall down. So AVF goes this way, straight down. AVR, on the other hand, is something that goes towards the R stands for right. So AVR will go this way. And AVF, on the other hand, goes that way. So as you can see, they all pretty much relate to the direction that they're talking about. And, oops, sorry, AVR should be this way, and AVF should be that way. So pretty much they all talk about the direction that they're describing. Where it gets a little bit hard is when we move on to V1 to V6. Now these waves can't really be quantified in terms of a specific direction because they don't move in a 2D plane, rather they move in a 3D plane. So if we look at V1 to V6, and if we look at the heart as a cross-section like that, with the right atrium here, right ventricle here, left atrium here, and left ventricle here, V1 to V6 basically go into the heart like that. So 1, 2, 3, 4, 5, and 6. And I do encourage you to look at Google Images to see more detailed pictures about this. But essentially, these leads are piercing into the heart and looking at essentially cross-sections of the heart as the electrical impulses pass through. And this cross-section gives you an idea, say if there's anything wrong with the septum of the heart, if there's anything wrong in terms of the maybe anterior wall, lateral walls, posterior walls. So it gives you a electrical image of where electrical impulses are flowing through in the heart, and whether there's any issue in terms of maybe a myocardial infarction that is affecting a particular area of the heart and causing death in that area. So that's basically an indication of the very basic things that you might see in an ECG trace. One final thing that I want to talk about, and this will only come with experience and maybe a little advanced for basic ECG interactions or indications, is the presence of ST elevations in myocardial infarctions. Basically, when you're looking at an ECG and you see an ST elevation, you are basically indicated that there is some damage to the myocardial wall. Now, if I draw a heart here, so once again we have the right atrium, right ventricle, left atrium, and left ventricle here, we can essentially identify where an ST elevation has occurred based on which leads have an ST elevation. Now, this isn't always correct because, as you all know, coronary arteries, coronary veins always have some sort of, I guess, a little bit of variation between them, but we can pretty much, quite accurately actually, measure where an ST elevation is occurring in terms of where it is on the physical heart. So usually you'll be given a table that shows you all of the leads in terms of the ECG trace and where these leads correlate to in terms of a physical structure. But the way I like to memorize it is in terms of the actual structure of the heart. So we have the heart here, and this is pretty much what the heart looks like in the chest, because as you all know, the right side is on this side and the left side is on that side. Basically, I like to translate the ECG leads onto the physical structure of the heart. So what do I mean by that? Basically, if you remember on the ECG lead, I'll just draw a little reference here. We have lead 1, lead 2, lead 3, if you can remember back to the picture that I showed you before. Then we have AVL, and AVF. Then we have V1, V2, V3, V4, V5, and V6, and they have their various waves represented across like that. I like to translate this data so that it's represented on the actual heart. So let's do that right now. So let's put lead 1 there, lead 2 there, lead 3 there, AVR here, AVL here, AVF here, V1 here, V2 here, V3 here, V4, V5, and V6. Now we've got a representation, and I'll just quickly clear the atrium sign just to make it a little bit more clear. Alright, so we've got all of our leads here. Now, if you see an ST elevation in particular leads, you can identify where that ST elevation or where that myocardial destruction is happening. Now, the reason why I've represented this in terms of places on the actual organic heart is because the placement of these leads can show you where the ST elevation or the destruction is occurring. So V5, as you can see, is on the lateral part of the left heart. So coincidentally, or by my model, if you see an ST elevation on V5 or V6, it shows that there is some sort of myocardial destruction occurring on the lateral side of the heart. And the same truth lies for lead 1. Now, lead 2 and lead 3 are getting more so towards the inferior side of the heart. Lead 3 is pretty much on the bottom of the heart. So lead 3 and lead 2 show if there is an inferior infarction occurring. AVF is pretty much on the bottom of the heart as well, so we can include that as an inferior infarction. AVR, as you can see, pretty much is in the right atrium, but it's in a place where nothing really would infarct. The right atrium is not really an oxygen-hungry part of the heart. So as you'll learn, if you see an AVR ST elevation, that does not show anything. If there's an AVR ST elevation, you can pretty much say that there's no damage occurring to the heart, and an AVR ST elevation pretty much doesn't occur. If there's an AVL ST elevation, then we can say that there is a lateral, because once again, this is on the lateral side of the right side of the heart. So AVL ST elevation show lateral damage to the heart. On the other hand, if we look at V1 and V2, and if we visualize the septum of the heart running across like that, separating the left and right sides of the heart, we can see that both V1 and V2 are pretty close to the septum. So we can say that if V1 or V2 are elevated, then there is a septal infarction occurring. Now V3 and V4 are unfortunately where my model sort of doesn't perform as well as it does for the other leads. Essentially, V4 and V3 represent the anterior sides of the heart. And I have tried to come up with some various ways to remember that, oops, I don't know why I wrote lateral there. Various ways to remember how to, I guess, memorize that these are anterior sides of the heart, but the best ways that I have come up with is that because V3 is close to the apex of the heart, and apex starts with A, anterior starts with A, it's an anterior lead. And because V4, in the way that I've drawn it, is close to the left auricle, A auricle, A anterior, I guess that's an ST elevation that shows an anterior side of the heart. But those two are basically two leads that you will probably just have to memorize. So in review, we quickly looked at the ECG trace and how to calculate the heart rate as well as any changes in rhythm as well as a sinus rhythm that are occurring. And by a visual representation of the heart, we were also able to look at how an ST elevation on a heart is represented in terms of a myocardial infarction organically on a heart. So I hope all of that made sense today. Thank you very much for watching.